Hi, good afternoon, everyone. Sorry for the slight delay as we work through our audio issues, but I think we've got everything worked out both in the room and for folks joining us virtually. Welcome. My name is Krishna Udaikumar. I'm a faculty member at Duke University in the US and also the Executive Director of Innovations in Healthcare. And it's my great pleasure to welcome you all as the moderator for this session focused on developing and implementing sustainable surveillance systems for antimicrobial resistance. And we're going to hear from leaders and stakeholders at the site level, at the national level, as well as regional and global level. So what we're going to try to unpack over the next hour and a half are really the major issues as they relate to antimicrobial resistance and surveillance and sustainability for these programs. So how do we actually make sure that surveillance programs can grow over time and that they can be put in place sustainably at multiple levels? If we go to the next slide. We'll be joined by two esteemed speakers here in person and two joining us virtually that you'll be able to see on video here as well. We've got Dr. Yewande Alimi from the Africa CDC, where she is the lead for AMR and One Health. We've got Dr. Janet Medega, who's a senior research manager at Wellcome. We've got Dr. Watipaso Kasambara, who's the national AMR coordinator for Malawi. And we've got Dr. Bernard Wanyama, who's the chief pharmacist at the Kakamega Teaching and Referral Hospital in Kenya. So great to have two of you with us in person, two of you joining us virtually. If we go to the next slide, I want to take just a couple of minutes to talk about why this is an important issue. As I said, today we'll hear perspectives from each of our speakers and then have enough time for a moderated discussion. So we want this to be as participatory as we can. So please join in after the presentations. We want to hear from all of you as well. If we go to the next slide. I think part of why this is important is that we're on a continent here that has the highest mortality rate from antimicrobial resistant infections in the world. And yet we also have a challenge with the data to make sure that it's timely and representative in terms of what we're actually seeing with the surveillance. And thus the need to develop stronger systems for AMR surveillance that can be scaled and also develop the data systems to put that information into practice more effectively. If we go to the next slide, we'll see if we go even further out to 2050 that this is going to be a burgeoning, not just epidemic, but pandemic of antimicrobial resistance in many parts of the world, with perhaps the largest burden here in Africa. So while we deal with a lot of outbreaks and we've dealt with pandemics in the last few years, this is something that unfortunately has continued to grow as a threat to all of us over time. If we go to the next slide, you'll see that part of why we're talking about this today is that we all have been part of a program called SPIDER, the Surveillance Partnership to Improve Data for Action on AMR, which is an offshoot of a program that Pfizer has been supporting for some time, the Atlas platform. And this program, SPIDER, has been supported both by Wellcome as well as Pfizer across 4 countries in Ghana, Kenya, Malawi, and Uganda. And we at Innovations in Healthcare have played a supporting role in helping those countries as well as the site teams think about how to develop models for sustainability for this AMR surveillance. Next slide. And, and as I've laid out, there's some clear challenges that we have to deal with here as we're thinking about the issues around AMR surveillance. First, we all know that ministries of health face tremendous competing challenges, whether it's for the last 3 years dealing with the COVID-19 pandemic, looking at generational setbacks in routine immunization. We're seeing challenges with polio, with measles, with other diseases along the way, and to prioritize AMR surveillance in the midst of that can always be a challenge for these ministries. Leadership is really required, and we have to continue to build strong leadership that understands and advocates for this issue. Challenges also come down to funding. In the same way that policy priorities are competing, funding priorities are also competing, not just at the national level, but all the way down to the site. When we're talking about supplies, when we're talking about reagents, we're talking about all of the things that are necessary for a system of surveillance to be in place. The clinical antimicrobial microbiological capabilities are also challenged at times. And then, of course, we have to have the data and communication systems in place. These have been some of the learnings over the last couple of years of the program that we've all been a part of. If we go to the next slide, what we've now tried to do is think about what's needed if we have a robust, high-performing system for AMR surveillance. It has to really link three of these things together. You have to have a provider at the front lines, right? This is really all about patient care and that provider being able to ensure that there's sample collection and utilization of microbiology services, and they have to be good stewards of antibiotics. So those feedback loops are really important. That has to then link to laboratory testing, which is critically important. So we need reliable, high quality supplies. We need equipment that can turn around results. We need rigorous quality control, and then that feedback loops back to the provider so that they can make better and focused decisions for their patients. And all of that has to feed into a system at a national as well as at a regional level to make sure that there's an understanding of what's happening, not just at any individual site, but across populations, and appropriate policy priorities can be set. What's needed across the board to make all of these functional? First, there has to be political will and funding to make sure that there are robust resources. Second, it's the human capital, the training, the competence, the ensuring that we're continuing to invest in people. And third, this is a place where we need much stronger community education and engagement to make sure that people recognize the role that they play in making sure that we as a community can be good stewards for antibiotics and in turn antimicrobial resistance. If we go to the next slide. Yeah. So this is part of what we've tried to build out, and part of what we're working on together with the 4 teams at the country level as well as at the site level is, can we develop a model for sustainability so that it's not just that you undertake these activities when there might be donor funding and then it goes away. So how do we think about national action plans? How do we think about models of sustainability? And these are some of the elements that we have collectively come to understand are very important for sustainability, and we'll hear much more about them as we go. So if we go to the next slide. Great. So that's a little bit of context setting. And I want to bring in now one of our virtual participants, Dr. Yewande Alimi from the Africa CDC, to provide us with a regional perspective and the work that Africa CDC is doing to lead this work on the continent. Dr. Alimi, the floor is yours.
And colleagues, my apologies that I cannot be there with you in person, but I think it's a really great pleasure, and I'm really delighted to see the spotlight on AMR, particularly getting regional as well as continental and national perspectives. So for this session, I'll be giving a bit of a background around the work that Africa CDC as well as technical partners and AU member states have undertaken over the past 3 years in our attempt to estimate or the burden as well as prevalence of antimicrobial resistance on the continent. Next slide, please. So maybe just as a bit of a background, I think this for many people is a first time engaging directly with Africa CDC, and for other colleagues, you might have known us in our a lot of the response work that we have done. But the work that Africa CDC as well as the African Union has been doing on antimicrobial resistance is particularly leading a high-level continental sort of approach for the continent and its member states to improve surveillance of antimicrobial resistance as well as antimicrobial use, as well as delaying emergence, thinking about things around stewardships, behavioral practices and barriers for prudent antimicrobial use. One of the other objectives of the strategic work that African Union has been doing is focused on limiting transmission. And particularly the African Union as well as Africa CDC is really leading the work around policies, statutes that promote infection prevention and control, biosecurity, good animal husbandry, as well as practices. Lastly, we have been working around mitigating harm when you think about things around stewardship guidelines for clinicians, veterinarians for susceptible and resistant infections. Our work is really anchored on the One Health approach by engaging all of the relevant sectors needed to combat and control antimicrobial resistance. But the unique thing about our work is because of the political power that the African Union has, our technical institutions such as Africa CDC were able to lead high-level political advocacy as well as working around human resources for antimicrobial resistance. Next slide, please. So this next slide, and of course, most of the other conversations that will follow, next slide, please, is really to showcase sort of the first
Hello? We lost all our audio. Check. Dr. Alimi, we've lost your audio.
Can you hear me?
Yes. Please continue. Sorry about that.
Hi, can you hear me now?
Yes.
Hello? Fantastic.
Yes, we can hear you well now.
Apologies, we can never trust the internet. The previous slide. So just very quickly, I'll try to do this as quickly. So what we try to do, next, please. What we tried to do over the past 3 years is really to collect and understand a lot of the gaps around antimicrobial resistance surveillance in our countries, understanding the gaps around the capacity as well as infrastructure and human resources. So what we did was over the past 3 years across the 14 countries represented, we did a retrospective collection and digitalization of antimicrobial resistance data. Of course, through this process, we went through, I think, about over 800,000 AMR records and data sets across these 14 countries. And some of the findings are particularly concerning. As Krishna mentioned earlier, Africa is currently reporting the highest mortality from AMR-related infections across the globe. Next slide. So very quickly, this is just to showcase some of the priority pathogens that have been that were identified across these 14 countries. One of the things that stands out clearly is the gaps around how AMR data is collected, the gaps around the capacity of countries, testing capacity, as well as human resource capacity. I'm glad that Watipaso is also on this panel because I know that Malawi has done a really fantastic job as being part of these countries, but it's really important to see how this data is going to feed into more policy-related issues as well as action action-driven interventions. And so one of the very concerning things we found across all these 14 countries is at the moment, it's only 5 of the 15 combination drug bug combinations that have been reported in these 14 countries. And of course, 5 of those pathogens are highlighted: Pseudomonas, Enterobacteria, Staph aureus, as well as Salmonella, being identified across these 14 countries. One critical challenge that stands out is the lack of unique patient data, unique patient identifier from the hospitals, as well as from the pharmacies that were involved in this study. Next slide, please. Looking at a bit about one of the things that we have called this is misutilization of antimicrobials. Next slide, please. Great, thank you. So as part of this study, in addition to the laboratory data, as well as the facilities that we collected this data from, we tried to understand across these 14 countries, the trends as well as prevalence or use of antimicrobials. And a few things are very concerning from these findings. One is that 86 of the WHO essential medicines reserve category drugs are not found in any of the national essential medicines list or documented as sale or consumption in these countries. 64% of the uncategorized antimicrobials currently found in these countries were not listed in the WHO essential medicines list. This gives us a bit of a concern as policymakers on the continent, because we have to then battle the issues of access versus excess. Next slide. So in trying to understand what this really means for the continent in terms of the priority pathogens identified, the trends of antimicrobials are consumed, we try to use an estimate, the drug resistance index, to try to calculate what the AMR hazard is for the continent. And from the slides you can see, that it's particularly concerning, with the highest rates being reported at about 74%. Next slide. To try to help you understand a bit what this means and to give a bit of a context across the globe, this is a single metric that tries to combine the measurement of resistance as well as consumption. Usually there's a value from 0 to 100 in trying to understand lesser antimicrobial effectiveness. If you look at this chart, you'd see that the United States is colored in blue. And in comparison to our 14 countries that were involved in this study, you can see how high our drug resistance index is. Ideally, it should be less than 25%. But as you can see, many of our countries are way above the 50%. Next slide, please. So this just to showcase some of the already existing initiatives that we are doing across Africa. As part of this as well, we're trying to strengthen and improve the quality of antimicrobial resistance data coming out from countries. And in collaboration with ASLM as well, and funded through the Fleming Fund, we have this EQA regional initiative where we have now 3 centers of excellence, including the NICD, which has been the WHO regional collaborating site for external quality assessment. This is particularly important to ensure that the quality of AMR data that is being generated is of good quality and can inform evidence-based actions as well as policies. Next slide. So very quickly, because I will talk a bit more about this during the facilitated discussions, a few critical things are needed for the continent. One is primarily we need to increase the volume, the quality, relevance, as well as representativeness of the laboratory data. At the moment, across the 14 countries, the percentage of laboratories doing bacteriology is currently at 1.3% across these 14 countries. And at least for us as Africa CDC, the goal is really to ensure the coverage across the continent reaches a 50% mark. In addition to this, all of these relevant findings are particularly important for the countries as well as healthcare facilities to adapt their national AMR control strategies, think about the national AMR plans, think about the surveillance protocols, think about also updating and enforcing national essential medicines list. But most importantly, this can also lead the continent towards where the priority should be for AMR research, as well as how to have innovative laboratory technologies. And in this case, I would easily think about genomics for AMR surveillance. Next slide. And I think that's about it for me. Thank you, Krishna, for having me participate virtually.
Thank you so much, Dr. Alimi. Great perspective. Got a bit of an echo that we're working on. Great. Thank you so much for that perspective from a regional and continental perspective, and the leadership there and the partnerships that are really required to make progress here. Let me now bring in our other virtual participant, Dr. Janet Adega. Welcome. AMR and surveillance for AMR is an issue that's been really a major priority for Wellcome for many years, and love to hear from you the perspectives. Janet, over to you.
Thank you very much, Dr. Krishna, for the opportunity, and apologies that I'm not able to be there in person, but I'm just going to give you our perspective from Wellcome, and our perspective is based on some of the lessons we have learned from the work we have funded and the opportunities that our work that we have funded has opened for us in terms of working on AMR across the African continent. So next slide. So as Dr. Alimi has mentioned, AMR, of course, is a global threat. Urgent action is needed because AMR is reversing the gains that have been made by modern medicine. Next slide. Next slide, please. And from the year 2018 to 2022, this February, Wellcome funded the GRAM study, which was the global research on antimicrobial resistance. And this was a 4.5-year project led by the Institute for Health Metrics and Evaluation at the University of Washington and the Big Data Institute in Oxford. And it was funded by the Fleming Fund, the Bill and Melinda Gates Foundation, as well as Wellcome. And the key goal for us was to estimate the global burden of AMR based on drug-bug combinations that are from the WHO priority pathogen list. And this allowed us to create methods that would allow the burden of AMR to be estimated. Next slide. So what were some of the findings? This work showed us that there were 1.27 million excess deaths attributed to AMR, and 4.5 million deaths were associated with a drug-resistant infection. And a greater number of deaths occurred in Africa, with 250,000 deaths each for 6 pathogens, namely E. coli, Staph aureus, Klebsiella, strep pneumonia, Acinetobacter, and Pseudomonas aeruginosa. And we also found from this work that the all-age death rate attributable to AMR was actually highest in Africa, with 27.3 deaths per 100,000. Next slide. So what were the key takeaways from the GRAM work? The key takeaways were that these new estimates have revealed the magnitude of deaths as a result of AMR. And we did look at data only from the year 2019 because that was the most robust data set from the sources of data that we were able to interact with. So this showed us that the problem of AMR was real. It still is real. It is urgent, it is relevant, and it is also preventable. Next slide. The other key finding, if you look at this graph, you can see that the prevalence of antimicrobial resistance varies. And the redder the color, the more red the color, the greater the resistance. So you can see that on the African continent, the prevalence of resistance is very high. But if you go to the Asian and American countries, the prevalence of resistance is much lower. So you find that in Africa, AMR disproportionately affects young children. And in 2019, 1 in 5 of those deaths occurred in children under the age of 5. Next slide. So what have we learned? As we were doing this study, the study was very data intensive, and we did a lot of data gathering from research organizations, from ministries of health, from research consortia who have done work on AMR. And so one of the main things we found out was that there is no data. And those who have data held in paper in a form that is not fit for purpose. And therefore, it made it very, very difficult for us to get high quality data to be analyzed. Apart from that, we also found that the data was never complete. A lot of the data did not have patient outcome data. Either this patient was treated with this medication and they healed well, or the outcome was death due to failure of treatment. So what this work has shown us is we are now aware of the pathogen drug combinations that are at high risk of AMR, and therefore there is the need for us to develop diagnostic and antibiotic stewardship measures. And so what Wellcome is doing towards the lessons that we have learned from the work we have funded is we are working with partners to develop research programs that can answer to some of the lessons that we have learned out of the research we have done. And one of these is the SPIDER project, which is part of this discussion today, which Wellcome is collaborating with Pfizer to do the SPIDER project in Kenya, Uganda, Malawi, and Ghana. The other thing we found is also that microbiology capacity is also lacking, especially in low and middle income countries. And towards that, we are also working with the 4 countries in our SPIDER project to try and improve laboratory capacity in terms of microbiology testing and antibiotic susceptibility testing in Kenya, Uganda, Malawi, and Ghana. And we plan to expand this to other countries in the second phase of the project. Next slide. So what are some of the opportunities that these have created for us? So I will expand on this later. So the GRAM work has shown us that AMR surveillance is important and needs to be improved both at the national levels and also at the regional level. The other thing we found was that AMR surveillance and even diagnostic activities were more focused on the isolate than on the patient. So towards this, we have developed and funded the ACON project. ACON stands for a clinically oriented antimicrobial resistance network, which is a project in 19 countries. And it's a project in 9 countries and 19 hospital sites across the 9 countries. And what the ACON project is doing is we have developed a protocol in collaboration with the World Health Organization, and we are trialing this AMR surveillance protocol advised by the data gaps that we found in our GRAM project. So we are trialing this protocol across these countries to try and encourage proper AMR surveillance data collection, ensuring that data points and metadata that are required for good data analysis and even AMR burden estimates are available across countries. Next, we also have the SEEN AMR project. The SEEN AMR project is similar to the ACON project, but it is taking a hub and spoke model. So the SEEN AMR project is Clinical Information Network for AMR, which is based in Kenya, working very, very closely with the Ministry of Health in Kenya and the Kenya Pediatric Association, so that we can bring a closer relationship between the health facilities and the Ministry of Health, so that we can have that crosstalk between the project and the Ministry of Health to enable the use for data to act for action, and also to enable the translation of data from these projects into policy. And next, we are also funding a second phase of the GRAM project. You will recognize that the first phase of the GRAM project only gave us AMR burden data at a regional level. Now, the GRAM 2 project is going to give us country-specific estimates of the burden of AMR. In addition to that, in GRAM 2, we are also now enabling countries to do longitudinal data analysis. In GRAM 1, what we did was we received data from countries, that data was analyzed and estimates of burden were given. This time, we are enabling countries to improve data collection, and as well as to be able to analyze their own data and be able to locally make estimates of the burden of AMR. So GRAM 2 has just been funded. It is yet to kick off, but that is the aim of GRAM 2 and how we would like to see it go forward, enabling countries more to collect data and actually use the data. Next, we also found that there was a lack of tools for AMR data collection. So our action as Wellcome is the CEDRILIMS project, which is a laboratory information management system development, which we have finalized the software development. We have piloted in 5 countries, and we are now opening it up to real world testing, where we are speaking to countries, and those that are interested are actually going to come on board and will be able to test this system in their health systems to see how best it works in their laboratories to enable the capture, the systematic capture of AMR data. So apart from this, we are also working very closely at the country level with ministries of health, and we are also working to strengthen capacity for AMR data analysis and the use of data for action. We have recently held an AMR surveillance data analysis project workshop in Malawi, and we will hold a second workshop next year about May and July. And towards that, we are also working towards coming up with a manual, which can be an AMR surveillance data analysis manual that countries can have in their hand to use to analyze their data and use it to inform action and even to improve patient treatment at the hospital level. Next. So I'll stop there in the interest of time and probably say more in the panel discussion. And thank you very much for the opportunity to present today.
Thank you very much, Janet. Great perspective and really a broad set of work that Wellcome has been supporting for quite some time. We've heard now at the continental, regional level, what's happening from a donor perspective globally that's really looking at all of the parts. Let's keep honing down and get to this national level where a lot of the action is, where national ministries of health have to make these decisions, figure out how the policy priorities are going to work. And to help us think through that, let me bring in Dr. Watipaso Kasambra, as I mentioned, the National AMR Coordinator for Malawi, and you've already been called out as an exemplar of a national response to AMR that we should learn from. So, floor is yours.
Thank you so much. And good morning. Is it morning already? Afternoon. Good afternoon, everyone. I see people gloomy faces, but let's smile so that you can give us signs that we should speak freely. So I will speak about our experience in building an AMR surveillance system. There are a number of things we've done, but I'll focus on what we've done on the AMR surveillance. Next slide. So as Wande has already said, on the map work we did, we take pride in that work which we did throughout the 14 countries, because it really gave us a landscape of what is happening in the countries. We've been talking about this AMR is a challenge in Africa, but how big is the burden? I know we haven't yet quantified how big the burden is, but we can pick up pieces of data sets and say, I think we have a problem. So I think that's also one thing which we're so proud of being part of that work. But from our Malawi the burden of disease, we highly know that malaria, TB, HIV has one or the other contributed to the high increase of antimicrobial resistance. And that's why we still hugely talk about AMR being attributed to those 3 major infectious diseases. So from the baseline data of MAP, we saw from Malawi, you've even seen, I think we are one of the 2 countries with a very high drug resistant index at 74%. So from our database for Malawi, we saw that we had high levels of resistance noted in fluoroquinolone resistance in Neisseria gonorrhea, about 68% to 83%. Enterobacterial resistance in carbapenems, and MRI says as one of our huge main issues on resistance. Next slide. So as all the other countries, what we started doing, looking at that data and understanding our scope that this is a problem, we developed the National Action Plan in year 2017 to 2022. It has expired right now. And we still carry the same goal as any other country to make sure that we have continuity and successful treatments, but also there is quality assured medicines and they are used to those who truly need them. Next slide. So what has happened over time? One thing which has happened, we have built up a strong leadership and effective governance. That's one of the key wins which Malawi has done. So Malawi set up an AMRCC, not embedded inside other departments, but within the Public Health Institute of Malawi, Malawi set up an antimicrobial resistance coordinating center to make sure that there is a good coordinated approach in implementing antimicrobial resistance. And this was set up as One Health. So Minister of Health coordinates all AMR activities on One Health approach. So we did set up that leadership and have a very good effective governance. Through that, we've seen there's a very active TWG functional technical working group. So our country structure, we do not have a steering committee. Our main approach, main committee of implementing strategies, it will be a TWG. So we were approved to have our own standalone TWG to monitor implementation of antimicrobial resistance as One Health approach. And also we have enjoyed, I think he's just left, we have enjoyed the strong leadership of the permanent secretary for the Minister of Health. He is the chair of the TWG, but he is also a very strong force to drive AMR implementation. So those are some of the critical things which have happened in Malawi. The second thing is effective coordination. You can set up an MRCC, but if there is no coordination, you have fragmented programs. So we have made sure that there is a strong MRCC, which is trusted, and all activities are tailored into that MRCC. So if you come to Malawi, you want to work on AMR, you need to come through the AMRCC. That's where you'll be guided that this is the structure of how we are working and you are in these areas working. So primarily that's what we've done. And also the AMRCC has been so much equipped to do coordinate activities, write grants. So like the Fleming Fund, the ICAS, the SPIDA project, these are things run under the AMRCC. And it has brought in a lot of capacity building, because if you talk about trainings, you talk about other programs which are coming in, you start at the AMRCC at the national level, because this is a new phenomenon and you need as many healthcare workers trained to tailor the interventions properly. So that's what we have tried to do. So if there's a program, let's say there's a Fleming Fund fellowship program, it will come to the AMRCC because we need to train the individuals there so that they can be able to effectively implement activities. Next slide. So this just shows our sketch of the MRCC. It's been engaged into a couple of activities. And another thing which I didn't mention, Malawi has a very young population of 25 to 45. So we have young people. So you can see very young people who are very energetic and they're very passionate about bringing change and understanding the burden on antimicrobial resistance. So that picture is our visit by the Fleming Fund. They came to appreciate how we have set up the structure, and it was really high with the Minister of Health having a podium. Next. So one thing which we've done is also progressive capacity building. We need to train the people at all costs. So we have done that progressively from the animal health, from the human health. So we have a project, let's say, for example, under the SPIDA on capacity building. We are training the focal people to make sure that they understand, because if they do not understand, then the facility will fall apart. The system won't be very much sustainable. So that's one thing which we're trying to do. Another thing in our AMR surveillance system is data. We know that we are building data, but the data, is it being utilized? So we set up a system, we built in a good data infrastructure through the WHONET program. So what we're trying to do is to make sure that the data which we are building is utilized. So for instance, we have finalized reviewing our standard treatment guidelines together with the essential medicines list as per the guidance from the MAP work which we did. So the data which has been used was the MAP data, but also the surveillance data which we're collecting on daily basis. We have also reviewed the sexually transmitted infection guidelines. These guidelines are syndromic treatment guidelines, but right now we've been able to review these guidelines through the data which we have, because you've seen in our data set that we have a challenge of resistance in Neisseria gonorrhea. So we've done that. We've also been critically using point prevalence survey as one of the key tools to understand the antibiotic uptakes at facility level. So in these two facilities where SPIDA is working in Kamuzu Central and Queen Elizabeth, there is ongoing point prevalence surveys on antibiotic use, just to understand, because the figure is alarming, 74.6. You really need to understand what is happening on the ground so that you can have good interventions to improve systems. And another thing which I've said is we have built a data management system through the same HUNET. So the same HUNET, which is run by the WHO, by John Sterling, we've built up a data management system where we are able to see the data using HUNET backlink, software backlink. So we're able to see data coming through our entries on our servers on daily basis. Next slide. So that's the data infrastructure which I was talking about. And within there, we have built a central data warehouse where we sit in and we manage the data on daily basis. And this data comes in real time. So at a facility A, when facility A is doing the entries of data, every evening there's an online storage into the central data warehouse. And with the SPIDA project, what Janet said, they helped us to clean the data. So we are the facilities able to clean the data, and we can even at the reference point, we can even recall a sample. If we are seeing these figures, no, they're not tallying, we can recall that sample for quality control, but also checks and balances. One thing which we've also doing right now is to make sure that there's utilization of this data at local level. So what we have done is to integrate AMR surveillance into the IDSR. You know the IDSR, the Integrated Disease Surveillance and Response Program, because that's a surveillance at country level, surveillance of any disease of priority. So, but for AMR, you know, the surveillance is pathogen specific. So we couldn't tally the data with our pathogen surveillance. But what we started doing right now, we have our own AMR surveillance within the IDSR, and we are running it every quarter. There's data. So at country level, you can be able to know that, okay, this quarter, this is the resistance level at a country. And this data is also pushed to DHIS2 because that is where it's critical. So the OHSP system is where we are pushing data through the IDSR system. Another thing which we are doing, we want to monitor antimicrobial consumption. What is coming in? What is at the border? What has been registered under the pharmacy and regulatory body, and what is at the central warehouse? Malawi has a central medical stores. So at even the central warehouse, where are these units going? At the facility level, you know, those who are doing pharmacy, there is open LMIS system. So this data system this software is linking to OHS, to the open LMIS system. It's in demo phase right now. We are hoping to carry it over in the next phase of our Fleming Fund grant, but it's coming out very properly. We really want to understand who is dispensing what, because we know that we've got challenges. Many of the prescriptions are done according to what is available. Is this really advisable to do that? Of course, there are a number of things bottlenecks to this, but we need to understand what units are available, what molecules are in our pharmacy, and how are we dispensing it. Though we are collecting it through the point prevalence survey, but you know, it's not routine, it's once a year, but we need a routine system where we can know that in ICU, these are how many units of meropenem have gone to that system. So that's one thing which we're trying to do through that portal which we have developed. Improved diagnostic capacity for laboratories. I will not overemphasize. This was highly work which was been done by the Fleming Fund, and they have capacitated these 11 laboratories, 8 human health, 3 animal health, and even in the SPIDA project, they are also working in the same laboratories. So what do you do in Malawi? You don't also come to start again. You build from what the other funder has already, because we're looking at sustainability, but also understanding to utilize the resources very, very properly. So that's another thing which we're doing. At the end of the day, we have quarterly reports. We have, so the facilities are able to generate quarterly reports and present to the stewardship committees, and the drug and therapeutic committee, they will make decisions with the data which they are seeing. Annually, all these reports, now we report annually, we have an annual report, and then we have the glass submission. Our surveillance on AMR is not only bacterial surveillance. We have antimicrobial consumption, we have pathogen surveillance, all this under one roof as surveillance, because we do not want to start this surveillance and then we come again and start another surveillance. We are doing it concurrently so that we can be able to understand. When we did a drug correlation, as they said, we saw that one of the recommendations, we need to walk this road together. Don't start another program and another one will fall apart for later. So I think those are some of the things which we've learned. Next slide. So that's our national AMR surveillance system. We selected the laboratories according to the region, because we know now that, yes, it's 1.3%, but our throughput on samples, I think one day did not go further to understand the investment which we have done. Are we seeing samples coming? That's the challenge. We're not seeing samples coming. So what we're trying to advocate a lot right now is to have the samples so that the facilities, the improvements, the equipment, we can be able to utilize. So we have the 3 regional labs and we have got the 8 surveillance labs managed by the National Microbiology Reference Lab. Next. So what have we done? We were doing this just trying, piloting. So right now we have a harmonized AMR surveillance guideline. It's up running. It's in the Secretary of Health desk. I wish he was here. He would have seen that the booklet is in his office for endorsement. But we have already disseminated this during the WOW week. We had a big WOW week and we disseminated the surveillance guideline. It is very context specific. It's from the lessons we've learned, the system which is happening right now. So we have developed the guideline according to what is happening right now in our facilities. Next. Going now to the facility level, it's now the AMS guideline. You cannot set up another AMR surveillance. No. Our break-in into the facility is stewardship. So we have also, in concurrently with the surveillance guideline, we have developed the stewardship guideline to be able to guide implementation and utilization of AMR, AMC, and all aspects of AMR implementation at facility level. We've tried, it's also under his office for endorsement, but we've also disseminated it in the AMR symposium, which we had last month. We have trained already a couple of 60 healthcare workers. We've set up 8 stewardship teams currently, which are very functional with specified TORs, specific annual work plans, and each team is responsible for AMR mitigation activities at facility level. So these ones we've also started doing at facility level. Next. We are now advocating for continued government support for sustainability. As they said, SPEEDA, Fleming Fund, ICAS, REACT, they will go, but we need to have a sustainable system which continues to grow, which is owned by us. So what we have done is to do HSSP prioritization. That's the Health Sector Strategic Plan 3. So this year, AMR has a strongly, we even have a paragraph, a full 2 paragraphs. Last time we only have 3 lines, but this time around we have a full paragraph, meaning that the ministry realizes that AMR is one of the greatest priorities within Malawi, and they need to put their resources into mitigating AMR. And another thing for this is the build up momentum, which we've done. We always go to senior management of the Ministers of Health and Minister of Agriculture and give them updates. Twice every year, we give them updates. This is what we're doing. This is what we've been able to do this quarter. This data, this is how alarming it is. The drugs which we have right now, this is one thing which is happening. So from there, we have seen a built up momentum within the governments to understand how can we all come together and build in a sustainable system for AMR implementation. And one thing which we're also doing is now raise the bar, make sure that the policymakers understand by how we are publishing now policy. We have a number of policy briefs which we've done. We are at local level even. It's not only through WHO and the Fleming Fund where we are publishing, but at country level, we are able now to publish within the newspapers. So you can see this came up in October, just trying to emphasize and echo within the country that we need to come together, raise the voice so that people can be able to understand what are the critical challenges and how can they tailor and how can they put in resources. Because now we need to talk about domestic funding right now so that we can be able to improve our system. Next. So these are some of the work which we have done recently. A review we did it with WHO, this policy, just to critically highlight what are the critical gaps in addressing AMR. And this has also helped us as we review our National Action Plan. We already have a policy brief which has highlighted critical 10 areas of priority focus according to our context. So as we move forward, we are really understanding how can we progress? How can we make sure that our National Action Plan is context specific? We can be able to implement this according to our own setting and according to our own resources. Next. We have also done another review with the World Bank and WHO. I don't know if you've seen this, but I know, Liz, you've seen this, this work. It was just talking about if we cannot put effective governance in place for AMR, then we cannot build in those 5 priority areas. So Malawi has critically highlighted an effective governance in building a sustainable AMR program. Next. So what are the bottlenecks? Access to resources dedicated to AMR is so difficult. You need to pull in resources. So that's why prioritization within the HSSP3 is very, very critical for us, because we know now from the government strategy, we will be funded properly. So if we do not have that, access to resources will be one of the priority challenges. And if AMR is also not in our health sector strategic plan or animal agriculture strategic plan, then we won't have a lot of partners coming to support these priority areas, because you know governments are supported according to the priority area in the health sector strategic plans. Human resource is limited. I know we have made a lot of progress. We have about 6 people sitting in our AMRCC office, but all these are not government. They are not government staff. These are program specific staff. Someone is coming with Fleming Fund, another one is coming with Pfizer, but we need government to dedicate, as they've dedicated Watipaso. We need more force to come so that there is continued support, continued sustainability in implementing AMR surveillance. Next one. So our next avenues, what are we doing? We are reviewing the National Action Plan. We are in the final stages of finalizing the review of the National Action Plan. And the review is context specific, incorporating the lessons we've learned. Our priorities are lessons from what we have done. Secondly, we have been ascertaining the economic cost burden of AMR in Malawi. This work is currently underway. It's very beautiful work. We want to understand how big, how costly is AMR. If we want to set up an AMR system, is it just $2,000? What are the critical things? When we're trying to set up these bacteriology labs, it's not easy. We need to be very realistic and say, this is how much investment it's going into this. So when we look about sustainability, Duke University, let's look at how big is the investment and can governments be able to sustain this? So primarily, that's what we're trying to understand. How big is the investment into AMR system? One day, I think we should be able to share this work as well. Now we want also to move from documents to action. We've set up a number of foundations through the last 5 years. AMR surveillance guideline, IPC guidelines, communication strategy on awareness, stewardship guidelines. We now need to move now from those documents to action. Let's start implementing. We are no longer in a phase of documents. We are in a now phase of implementing. Let's put money into action, put bodies into action and implement. So that's where we are going forward. And the last one is we want to advocate for data utilization. We know everyone is talking about data, but how are we utilizing that data? Are we making projections with that data? Right now we're talking about genomic sequencing, Really, have we utilized the genomic sequencing data from the COVID? So we need to be very realistic with the data which we are what? We are generating. So we want to utilize the data at a facility level where they are generating the data. That's why the SPIDA project is a very good source for us, because it's going into a facility, utilize the data for their own actions, understand the patient outcomes at this facility. So more engagements on knowledge translation, because the data people are supposed to understand. There is no proper understanding of how the dynamics of this data. So that's where in the next 5 years, we want to tailor our interventions to. Thank you so much. I can go on continuing. It's a very passionate field, but thank you so much for listening, and thank you.
Fantastic perspective of a really comprehensive and much to learn, and I think it really brought together a lot of what we've heard already. And you made the point several times where this really has to come together at the site level, where it has to make sense for the providers, the facility, and the patients that. So I want to now bring Dr. Wanyama, who's the chief pharmacist at Referral Hospital. Give us that perspective from a site level. There's a lot happening here.
Yes.
How does it play out on the front lines?
Okay, thank you very much. Good afternoon.
Afternoon.
I'm also the AMR focal person for the facility and the county. So I just want to showcase what is happening now at facility level with the support of SPIDA, PHISA, Wellcome Trust, and Micron Research. We've already talked about SPIDA, so we know what it is. This is a multi-centered project happening in 4 countries, 8 sites. In Kenya, we have 2 sites. Kakamega is one of the sites for the SPIDA project. Next. I'll just focus on the aim of this project. What do we want to achieve? We want to make use of data for decision making. At the facility level, are we utilizing the data we are getting from the lab for clinical decision making and probably for policy? And that is what I'm going to showcase. Next. So what are we doing? What are we collecting at our facility level? We are focusing on 5 WHO priority pathogens. There are 15, but our focus is 5. That is E. coli, Staph aureus, Pseudomonas aeruginosa, Acinetobacter, and the Klebsiella species. So we are collecting data in terms of the isolates by site of infection. Then, of course, basic demographic in terms of the isolation date, patient age, gender, and all that. Once we get this information, we send the isolate to a national reference lab and also at another reference lab in Johannesburg, where we do re-identification and genomic sequencing. Genomic sequencing is only for MDR isolates. Isolates that show resistance to more than 3 classes of antibiotics. Next. We are also collecting data in terms of epidemiology, the site of infection. We are very specific where we are getting this isolate. Is it from blood? Is it from skin? Is it from urine? And all that. We are also interested in, infection and clinical management, the outcome. After managing the patient with the drugs that we have given and the results that we have gotten from the lab, what is the impact? So we are also getting information on that. And then also the status in terms of hospitalization, whether the patient, how long has the patient stayed in the ward? How long has the patient stayed in the ICU? And also in terms of the previous history of antibiotic use. Before the patient came to the facility, what antibiotics has this patient used? And with the results that we are getting from the lab, has it changed? Have you switched to a new antibiotic? And what is the outcome of the new treatment? We are also doing mortality, which is the infection-related deaths, whether it is related to the infection that we are managing or other causes. So the data that we are collecting is to guide in terms of the choice of antibiotic. that we are going to give this patient. Additionally, we eventually have host antibiograms. And with the time, we have developed what we call cumulative antibiograms. And these cumulative antibiograms guide our clinicians in terms of empiric prescribing. Additionally, they guide our clinicians in terms of how can we come up with guidelines. And I'm going to showcase one of the documents that we have developed in relation to the cumulative antibiograms that we have developed from the data we collected. Next. Now, how far are we? The SPEEDUP project was a pilot. Phase 1 was a 12-month pilot project. So far, we are done with the first phase of the project. We are in the second phase where we got an additional 12-month extension. This project has a national PI at the country level, who is the national AMR focal person. And then at the site, we have a site PI and a co-PI and other 8 members of the team. We are being supplied by, sorry, is there an issue? Is the connection, sorry. Pfizer and Wellcome Trust is supporting all the 8 sites in terms of supplies and consumables for the lab. So what we do, we identify a local supplier, then Pfizer and Wellcome Trust pays for the supplies. Then they are supplied to the facility. We are also supported by Micron Research in terms of technical support. They do online monitoring and also physical visits to the site to assess the progress of the project. As per the contract, we are not able to purchase any equipment. So we build on the existing infrastructure, the lab infrastructure that we already have in terms of the freezers and all that. Remember, the isolates we are getting, we are freezing at -80 before we ship to the reference lab. So we build on what is existing to do our work. So what are we doing? In a nutshell, we get the consent from the patient, we collect the sample for quality and sensitivity testing. Once we get the isolate of interest, then we freeze. Of course, we'll have already subjected the isolate to sensitivity testing. We do disk diffusion testing. There are 2 approaches. Either you determine MIC or you determine by disk diffusion. At our site, we do a disk diffusion whereby we report either the isolate is resistant, susceptible, or intermediate. Then we enter the data into an electronic data capture tool, which is managed and controlled by Pfizer and Micron Research. Once we have freezed the isolates, we will subculture when we have adequate isolates ready for shipping. We subculture, do the packaging, then ship to the National Microbiology Reference Lab for re-identification and MIC determination. We also ship to our reference lab in Johannesburg for whole genome sequencing for MDR isolates and also for further re-identification. And I want to report here that we have had 100% congruence in terms of identification, in terms of identity. If we isolate E. coli at our site, in our reference lab, we have also identified E. coli. So 100% re-identification. Next. We also follow up patients at 3 months and 6 month level. So what are the achievements so far in terms of this project? We have been able to revive our AMS program because we have a basis, we have the support. The AMR surveillance project came with the capacity building project. They were intertwined so that as we do AMR surveillance, we are also capacity building staff at our facility. So because of this capacity building project, we are able to revive this program, and we also have what we call the County Antimicrobial Stewardship Interagency Committee. In Kenya, we have devolved system of government where we have 48 governments. We have a national government and 47 county governments. So where I come from, we have a government, which is a local government. So this CASIC committee, the aim is for resource mobilization in terms of AMR surveillance. And with this CASIC, we've been able to at least secure some budget for purposes of AMR surveillance in the county. We're also doing AMR capacity building and we have developed antimicrobial treatment guidelines and protocols. And I carry the book here. The data that we got from the antibiograms was able to inform review of this document. This one is given to all clinicians who carry it to the wards, and they're able to make reference to it. We review it as we get additional information in relation to the local resistance pattern. Additionally, we have improved communication between the lab and the clinicians. Previously, we had challenges in terms of communicating the results to the clinical areas on timely basis. Results are out, but they're just put in a pigeonhole, or the clinician has to come back to the lab to collect the results. But we were able to come up with porters who deliver the samples to the lab, and again, they deliver the results to the ward. So anytime the result comes out, you deliver to the ward immediately so that a decision can be made. Lastly, there is also improve in terms of uptake of microbiology services. Previously, our lab was not doing much in terms of microbiology because of the supplies. But with the support of Pfizer and Wellcome Trust, we are able now to build our microbiology lab. Of course, we are basing decisions in terms of choice of antibiotics or antimicrobials from the results that we get. Previously, 80% of the prescriptions were empiric. There was no targeted therapy. But now we are shifting from empiric therapy to targeted therapy because you know the isolates and you are able to narrow down in terms of the resistance pattern. You decide which molecule you are going to give. Of course, the other issue is about ISO certification of our lab. By improving the services of the microbiology lab, it has contributed to ISO certification of this lab, because when they come and do the assessment, we have to look at all the departments, not just biochemistry and all that. We focus on all the sections of the lab. Then the other issue is about reporting of AMR data to national surveillance system. Previously, we didn't have much to report. And again, we were not even registered on GLASS. But right now, we are able to report our AMR resistance data to the national surveillance system. Next. Despite these achievements, we have challenges. And the first one is over-reliance on donor funding. I want to start with that one. Because our question is this: once these projects are over, what next? However, we are trying to put in some mechanism to sustain the gains that we have made by ensuring that the county government and the national government put something in terms of AMR. And this financial year, we have managed to just generate a vote in our county budget, and we secured some funds for purposes of AMR. It may be a small amount. However, we start from there. With the time, every year we do supplementary budgets, and the next financial year we do a budget, we build on that. Then the other challenge is in terms of, again, sustaining the reagents. We know our lab is very busy, the capacity is very high, there are very many competing needs: biochemistry, hematology, pathology, and all that. So the funds that we get may not be able to sustain the microbiology services. Microbiology is very expensive. And for the lab guys who are in this house, they know very well. So it is capital intensive. And we want to shift from using the manual systems, which we are using currently, to an automated system. Because one of the challenges you can see there is the long turnaround time for blood cultures, because we are doing manually. But if we are able to acquire automated machines, like the Vitec 2 machines, we could be able actually to reduce the turnaround time, because clinicians also want to get the results on time to make a decision. But if you give me blood culture results after 20 days, probably the patient has been discharged, has died, or something else has happened within the ward. So we want to reduce that long turnaround time, but probably acquiring automated machines that can give us results in a short while. We are also doing capacity building of our staff, but the biggest issue is that our facility is a training and internship center. We capacity build our staff, but probably they go somewhere else, or they finish the internship and move out. So it means that we have now to have routine capacity building or a routine mentorship program, so that we continuously do the capacity building. Because we capacity build people, we have skills, but they leave and go somewhere else. The other issue is weak capacity for data in weak capacity for data use in decision making. What I mean here is that sometimes we communicate to the clinician that we have isolated Staphylococcus aureus, and it is showing that it's resistant to oxacillin. So what? Some of them cannot deduce that probably that one is an MRSA. So they look at the results and it doesn't make sense to them. Others may get a result that says this bug is, the resistance is intermediate to this drug. Now, if you report to me intermediate, what do you want me to do with that? You are not telling me whether it is resistant, whether it is susceptible, you are saying intermediate. So it becomes very difficult for some of our people to make clinical decisions on that. So that is where we are in terms of our site. We are somewhere. We believe that with the support of the county government, the donors, and the other development partners, we are going to move somewhere in terms of AMR. And lastly, I want to say this, that going forward, for us who are in the space of AMR, we must ensure that AMR has a face. By saying AMR has a face, you know, in the era of HIV, it was very clear you can see someone with the HIV and you feel. But as in the field of AMR, do we have something that we can show so that we can have a call to action, so that people can come in and give in money, fund projects in relation to AMR? Does AMR have a face? So as you go back to where you came from, ask yourself, does AMR have a face? Can I look at someone and say, this guy has an issue because of AMR? Thank you very much.
Thank you. That was a fantastic review of how all these policy and donor funding issues play out at a facility and site level, and really some of the challenges of making this work, and the achievements that you've been able to show that they're Kakamega. So fantastic work here. I'm going to start into our open discussion now. We want to hear from all of you as well. So we've got my colleagues Jane and Wenhui, who will be bringing microphones around. We've got quite a few hands, so let's go straight to the audience. Okay, can we start here? Yeah, anywhere. So I'll leave it to, yeah. And please introduce yourself when you're, and if you're directing it to a particular speaker, please let us know. Here, we'll bring another one here. Try this one. Should we?
Thank you so much. My name is Farhan Yusuf. I'm a pharmacist from Tanzania, and I'd like to sort of pick up on where the last speaker stopped. First of all, great presentations. It's great to see all the work that's being done. But, as every presentation was talking about achievements and challenges, one of the things that I kept looking for was that someone will talk about community engagement, because I really feel like we have made the whole issue of AMR a very scientific issue, right? We gather in these sessions, we talk about it from a very scientific perspective, isolates, resistance, this person, but somehow this information is not going down to the communities. And I was very happy to see, at least, for Malawi, I think in the surveillance system, they're also including community pharmacies, not just hospitals, which is something that I think you don't see in many countries, but we're still not talking about how are we disseminating this to the communities, and how are we making this information palatable to the layman? Because until we solve that problem, really, because AMR for me is a supply demand issue, as long as the community keeps demanding, people will supply, right? It's a very money sort of based situation as well. And so until the communities stop asking for some of these things, it won't stop. So that's something, and it's a general question, if anyone wants to add on that, what exactly are we doing for the communities? How are we engaging them? Because again, even for the issue of resource mobilization, right? Governments will put these statements, paragraphs in their policies, but usually the money comes where people are making noise. And if no one is making noise about this at the community level, then that money will not really move. So.
Thank you. Very important point and question. And perhaps I'll ask my two colleagues here for their thoughts. We heard a little bit about this, and how do you put a face to it, and how do you make sure that this is not an abstract concept, but beyond that? Would you like to chime in?
it's good to see that we're thinking about community engagement. And I think I want to echo the words for Bernard that, you know, AMR is not a disease. So you really need to craft it very properly, that at a community level, they should be able to understand. We are buying a leaf from the community health engagement programs. So that's where we're moving into our surveillance for AMR. But we are willing to learn, because, you know, in AMR right now, we are learning every day new strategies in each country, how they're doing it. So I think we should have, Liz, maybe one time WHO have a platform where we can be able to know and learn how can we tailor interventions into the community. In my country, we have tried to engage at a community level through, of course, awareness. We have done a collaborative dialogue on AMR just to help to understand the landscape of what are their thoughts on antibiotics. What are their thoughts on resistance? And our WOW week, we used those messagings to reach out to the community. We have tried the mobile system during the WOW week to reach as many people as possible. Call-in programs. When someone checks a message, you have an AMR message down there, but we have a lot of feedback, and we are learning how can we reach so many people in a language they can be able to understand. So we are still learning, I would say that.
Just to add, in Kenya, we are also having a media engagement through local radio stations where we engage the local communities. In addition, in our facility, in our health facility, we have documentaries that we have developed, and we have put them at strategic points at the waiting base, at the pharmacy, at the lab, at the accident and emergency center, and at the outpatient. So as the clients were to be served, they're able to watch a documentary on AMR. We are doing something. I know it is more that is required from us, and governments must also bring in. The problem in Africa, we struggle with the issue of access versus excess. There are some regions where there is access to antibiotics, and others there is limited access. So you have to balance that. Again, we don't want our people to struggle getting these antibiotics or the drugs. So like in Kenya, I think we are no longer struggling with access. The issue we have there is excess. So now that we have reached the level of excess, what are we supposed to do? Is a question for you. Thank you.
Thank you very much. My name is Shem Utoisam, a research scientist from Lake Region Economic Bloc, Kenya. I have two comments that are interrelated. First, let me congratulate Malawi for good work they're doing. I have observed among the presentations made here that AMR is under-resourced, especially by the African states. Have you thought of something? If all the external support we're getting in MR just went away, what are we to do as a continent? There was a joke during the time that COVID vaccine was being generated, and it was said that 54 countries are waiting for vaccine from someone. We do not have the capacity. So when we're going back where we come from, can we engage our countries to fund AMR instead of waiting for donors with their own agenda to do us? We need autonomy. That is one. In terms of diagnostics, we have, I'm concerned about cross-border and in-country surveillance. Why must samples be taken to central laboratories so that the turnaround time is more? We should have the capacity for in-country and cross-border surveillance without relying on central laboratories. Thank you.
Thank you. And for the sake of time, we're going to take 3 or 4 questions together and then ask for comments. Who's got that? Why don't we go here and then back?
Good afternoon. My name is Osvaldo. Come from Mozambique, National Institute of Health. I have one opinion and one question. I think so is AMR is problem to speak in English, not speak to French or Portuguese. Look at this presentation. All countries speak in English. We don't have experience with French or Portuguese country. We asked my colleague from Angola, do you have problem of AMR? Yes, we have. We see in the map the high burden of AMR in which our country. But my question is from Malawi and Kenya. How can you use One Health approaching to data sharing and data use in your country? We looked for your presentation. We look only for health, human health sector. But how can you use the data sharing and data use with One Health approach?
Thank you. We have more here? Yes, please.
My voice is generally high, but I think it's, yeah, thank you very much. My name is Nicoletta Dentico, and I am the director of the Global Health Justice Program of Society for International Development. It's a long thing, sorry. But well, first of all, congratulations. It's so great to see such good warriors, you know, fighting the good battles. However, I needed to kind of insert a little bit. Of course, we are talking about surveillance, but I was triggered. I could not resist after your comment. It is, yes, certainly a question of involvement of communities. The whole debate has been about mostly antibiotic resistance. Of course, you said, good warrior, that you're also looking at other pathogens, but you're mostly concentrated on human health. Whereas we know very well that AMR is not only is this not a disease, but it is mostly something that has not to do mostly with human health. This is something that has a huge animal health, structural animal health driver, which is connected to animal farming. And also, when it comes to human health, it has got to do with the industrialized model of agriculture. The resistance provoked by, for example, glyphosate has been discovered in Africa. It was discovered in Tanzania. Some remote communities that had never been exposed to antibiotics were resistant to antibiotics because of glyphosate Roundup in the vicinity. So, I mean, with all this very amazing job that you're doing, you talk about One Health, but my questions are, I have a series, I mean, many questions, but the first one would be, don't you think that this concentration on pharmacists, doctors, it's a bit of a driven agenda to basically deal with AMR once again as an infectious disease, which is not. Two, what are you actually doing in your work, in your document elaboration, which, as you said correctly, now needs to move into action and implementation? How are you actually looking at One Health? What is it, One Health? Because I think One Health in the international community is more a metaphysical or philosophical evocation than something that is really operationalized. One Health is so much more than surveillance and control. So what is your One Health? Thirdly, don't you think, and finished, don't you think that together with all this very scientific job, a more policy job to work at the prevention and therefore at all the policies that are non-health policies need to be set in place in order to, build on your fantastic job. Thank you.
Great, thank you.
Thank you so much. Let me just do a quick response. Our surveillance is not only human health. It is One Health. When you go to our document, we have human health surveillance, animal health surveillance, antimicrobial consumption surveillance. I understand what you're saying. One Health, especially from the animal health, takes in a lot. There are a number of factors in animal health surveillance. Right now, what we have started doing poultry surveillance. Understanding, so we're doing a poultry surveillance right now, though the animals are working, but not on that harmonized approach. Next, we are moving into the cows. Next, we are moving into the dairy. So for animal health, it's really complex, but we need to learn a day at a time. We can't go flat out, we will be too much. We won't answer to so many things. We'll go back to the area where we are, putting resources where they are not supposed to be, but we are taking a step at a time. So our surveillance, I did not want, because we were only given 10 minutes, I would have talked about how now it is also in animal health. And we doing it as a One Health platform. From your question on data, let me explain to you that when we build in our data management system, it is a One Health data management system. So we have a central vet lab, which is managing the 3 labs. There is also a central data management system. Still, we are using HUNET because, you know, through the World Animal Health, we still do not have a number of platforms for a number of softwares to push in data, but we are using still the HUNET right now. So we have it installed in all these labs, and they have a central data warehouse. What they do also quarterly, they push online storage to the main AMRCC data warehouse. So we do have that data, which we normally report to OIE, which is Animal Health World nowadays. So it is also a One Health surveillance. We are not leaving anybody behind. We are moving together, but in animal health, we can't go flat out. We are going step by step. Thank you.
Thank you. Let me bring in Dr. Alimi, who also leads the One Health work at the Africa CDC.
Hi, can you hear me? Yes, so very quickly, I think what Pato has done a fantastic job already saying 10 minutes is not enough to unpack all of the issues around antimicrobial resistance. And it's quite important that the audience knows that we're taking just a tiny fraction of understanding antimicrobial resistance, and that is the surveillance part we have tried to focus on as panelists. Maybe just to respond around work that is being done on community engagement, which I think is a fantastic question, because if we're really going to change behavior change, community is the base. That's where we need to focus on. So at the level of the Africa CDC as well as the African Union, one of the things that we have tried to focus on is the engagement of civil society groups, as well as faith-based groups across the continent. Very recently, we expanded that particular advocacy portfolio to involve media as well as journalists. I think there's some of them around on this conference that have been in that sort of group of journalists and media that we have been training. I think one thing is particularly crucial. When we say we want to engage community, one of the mistakes that we have made as scientists, policymakers, technical people in the past is our messaging hasn't been clear. Is AMR a disease? What is AMR without a face? So I think one of the crucial things that we need to do as technical people, as the general population, is really revamp the message such that it is clear enough for someone who doesn't understand English, for someone who doesn't understand French, for someone who understands only local languages. What does that mean? What does antimicrobial resistance mean? So we are trying to ensure that we have all of these groups involved. But I think one important thing I thought to mention, particularly because CPHIA is really focused on having that youth engagement, having that youth platform, is that we have started recently engaging young Africans, because we believe that Agenda 2063 cannot be achieved by a lot of us. It would be very younger Africans on the platform across the continent that can move the messaging for us. So I think I just thought to mention that we have various platforms, continental as well as regional, that we're engaging civil society groups, faith-based groups, youth groups, farmers, and different various stakeholders. Just to mention that we are also doing a continental CAP study we have recently published how it's important for us to really understand a lot of the barriers. One thing about the continent is, as much as we are a continent, we need to understand that we are quite diverse in our reality. So for example, some of the challenges that you would experience in East Africa may not necessarily be the same reality in North Africa. So one of the things we and our responsibility as African Union and Africa CDC is to ensure that no country is left behind, no region is left behind. So it's important for us to have a very regional, country level, context specific measures to address some of this. In talking about issues of domestic financing, I think that was a really fantastic point. And it's really important for us as a continent to know that we cannot forever lean on external funding. We cannot rely on donor funding to change our continent. It really has to come from within. And this is why we as Africa CDC, in February 2020, one of the things that I think has been very pivotal to the change we are starting to see on the continent is creating that enabling political climate. So in February 2020, at the level of the African Union heads of state and government, there was a political a declaration towards antimicrobial resistance. They call it the African Common Position on AMR. And that political declaration is what we are anchoring on to advocate for better financing. But I think we must all agree that until we're able to define the problem, it's difficult to go to a policymaker to say, I need 100 million specifically for AMR surveillance without being able to define how much and the economic case for antimicrobial resistance. Africa deals with different sort of infectious diseases, non-infectious diseases, and we don't have a pot of endless resources. So I think the recommendation or the feedback to technical people in the room, representatives of national government is, as a continent, it is our duty now to start to make an economic case. For example, what is the cost of doing nothing versus doing something? If we're not able to define that, we're not able to get domestic financing. This is why this session is so important. And this is why AMR data is really important to lead into policy. And just to talk about the One Health bit, is that, yes, once again, it's a 10-minute presentation for us to talk about the amazing work we're all doing. Indeed, One Health is important. But I think one of the things that I feel is very strong is before we can have integrated AMR surveillance, or as you may call it, a One Health approach, every sector must be able to make investments in their capacity. And this is why it's important for colleagues from the environment sector in the room, colleagues from the agriculture, to start to make investment, to start to define where are the priorities. It's not a one-man job. So we need to all work together to get to where we want to see in this full One Health approach. But every sector needs to start making those needed steps towards integrated AMR surveillance. Over to you, Krishna.
Great, thank you so much. Unfortunately, we've come to the end of our time. I know it seems like we're just getting started. It's fantastic to see the engagement here, the passion in the room, and I certainly don't want to put an end to that. So I've been instructed to join us for tea afterward, right outside, or coffee, I'll add, for those of us that might prefer it. But it just leaves me to first provide a few thanks. First, to all of our speakers who've done a fantastic job of bringing to life what may be a hard to understand concept, but just recognizing really on the front lines at the national level, at the regional level, and then from a global perspective, what are all of the complexities that have to come together for us to be effective at addressing a really important and growing challenge that has been understood for many years now. I'd love to thank also my colleagues from the Duke Innovations and Healthcare team who are here, who are working in the US on this as well, for helping us manage all of this. Thank you to the generous support from Pfizer and from Wellcome for the program and for much of the work that you've heard about today. And thanks to all of you. I think this is a one step forward to try to build a community of many diverse voices to try to move this work forward. So thank you all for joining us today. And please do stay in touch with us and continue the conversation over tea. Thank you very much and good afternoon.